Welcome to the second part of our lecture on measures of association, where we're going to look at relative risks. We'll have a brief look at the population risks as well. Again, please note the textbook references in the specific pages where you'll find this information. As I said in the previous lecture, the objectives for this lecture and the last lecture are the same, but of course this time we're going to focus on relative risks. So for a relative risk, we're really asking how many times more likely are exposed persons to get the disease relative to a non-exposed person. So it's asking how many times more. It's a multiplicative statistic. And it's essentially the ratio of the risk in exposed to the risk in the unexposed. So as opposed to attributable risk, which was the risk difference, this is the ratio. So we calculate it as the ratio of the risk of developing the disease among the exposed group to the risk of developing the disease among the unexposed group. Looks very similar to the attributable risk, except instead of it being the difference, we see that it's the incidence in the exposed group divided by the incidence in the unexposed group. And thus we can also call relative risks the risk ratio. Relative risks are the most commonly reported risks, not only because they are easy to calculate, but because of the way relative risks are calculated, it allows a comparison of similar risk factors with different baseline incident rates. Because the relative risks indicate the strength of the association between exposure and disease, we use it very frequently in studies of disease causation. We return to our example of estrogen and breast cancer. By now, you've calculated the absolute risk and the attributable risk. So use the formula on the previous slide to calculate the relative risk, to have a go at that. And as we saw with attributable risk, you can calculate relative risk using our dichotomous table. Again, in last lecture, we saw this dichotomous table and we worked out how we filled it in and the format of it. And we saw how you could get the incidence in exposed and the incidence in unexposed through through using the various numbers in each given cell. So again, you can have a look to see how pulling the figures from the dichotomous table give you the similar results. And I've copied the answers here so we can see that when you take the incidence exposed and you divide it by the incidence in the unexposed, we get a relative risk of 1.27. But what does that mean? So let's have a look at how we can interpret the relative risk. Up in this corner, we see the formula for relative risk. Now, relative risk is always linked to 1 because it's a fraction. We see that if the incidence in the exposed is the same as the incidence in the unexposed, that's the numerator is the same as the denominator, then relative risk is going to equal 1. So incidence exposed equals the incidence in the unexposed, relative risk is 1. Therefore, when the relative risk is 1, there's no change in those two incidences. Similarly, if the incidence in the exposed is greater than the incidence in the unexposed, we can say that exposure increases the risk of disease. And if the relative risk is less than 1, such as if the incidence exposed is less than the incidence in unexposed, we can see that exposure is likely to decrease the risk of disease. So it's always linked to one. So if we take our example of estrogen, where we saw the relative risk was 1.27. 1.27 is bigger than 1. So the risk of getting breast cancer due to estrogen therapy is equivalent to a relative risk of 1.27, or you can express it as 27%. So 1 minus 1.27 gives you 0.27 times 127%. Let's look at how attributable risks and relative risks work together. We know that both attributable and relative risks are calculated from the same components. So that's the incidence in the exposed and the incidence in the unexposed. So why does that result in such a big difference? We know that the relative risk for our estrogen example is 1.27, whereas our attributable risk is 4.2 per thousand, or if you're thinking about the raw calculations, it's 0.0042. It's because the calculation of relative risk cancels out the incidence. So the population size is seen in both the numerator and the denominator. Therefore, it does not clarify the size of the risk. It's not a risk difference. That's what a attributable risk is. What it is doing is it's talking about the strength of the relationship. The benefit for relative risk is that we can compare slightly different risk factors in groups where there's slightly different incidence rates. But you can see that for a patient and the clinician, it's probably more helpful to use the risk difference, the actual size of the risk effect that's going to occur depending on the treatment or the lifestyle intervention or whatever it is that you're trying to do. To see how that plays out, have a look at the table that's there. Suppose a risk factor doubles the chance of dying from disease. So let's say that you've got twice as much chance of dying from breast cancer if you use estrogen than if you have breast cancer and you don't use estrogen, for example. In which case the relative risk is going to be 2. But it looks very different if the population size is different. So we see here that the population size is increasing this way, and our attributable fraction seems to be reasonably large in the small population size, and it gets smaller as you go up. If you were the clinician and or the patient, you're probably going to be more interested in what's going on here. If you get a death rate going up from 100 to 200 in a population of 1,000, that's much more concerning as a clinician and the patient than what's going on here, which is essentially increasing the death rate from 0.1 to 0.2 per 1,000 or 1 to 2 per 10,000. So this seems to be, the attributable fraction seems to give much more useful information at that clinician level, if you've got that data, of course. Quite disappointingly, relative risks are probably used more often because they're more readily available. But something for you to think about when talking to the patients about different risks. Just want to stop for a few minutes and talk about the reporting of the risk. Now, we're talking about this here in the relative risk factorial, but it's true for reporting of any risk. When we report risk, so when you're telling your patient that a treatment might have a risk associated with it or a lifestyle behavior might have a risk associated with it, there are 4 components that need to be included when we report the risk. We need to include the exposed group. We need to include the unexposed group. You need to include the risk, and I've got here relative risk because that's the topic of the lecture, but it would hold true for absolute risk, attributable risk, and odds ratio when we get to that, and the outcome. So you have to include all those 4 components. It doesn't matter the order in which you include the 4 components, but you must include all of the 4 components. Let's have a look at an example. The first example I've got there is estrogen users have 1.27 times the risk of developing breast cancer compared to estrogen non-users. So in the first example, we can see this is the exposed group. Here is our relative risk. This is the outcome, and here is the unexposed group. So we've got all 4 elements. So for the following 2, see if you can't identify all of the 4 elements. Also note when we come to the second and third examples that the relative risk here is expressed as a percentage, which is equally appropriate. It will be important for you going on to be able to report the risk, and that might be a good hint for your exam preparation. Have a look at this. This was a photograph that was taken off the highway between Churchill and Melbourne. Motorcycles have 38 times the risk of serious injury. What's missing? Identify the exposed group, the risk, the outcome. We're missing the unexposed group. So it's assumed, obviously, that motorcycles have 38 times the risk of serious injury compared to the car drivers because that is who's reading it. But if you rode along there on your bicycle, are they talking about 38 times the risk of serious injury on a bicycle? What about if you were driving a tractor along the road? Happens in country areas. Or a horse? Or a big truck? So it's a bit of a tongue-in-cheek example. We need to be careful. That's why we need to have all of the 4 elements so that there's no ambiguity and that the communication is clear. That brings us to the end of our look at relative risk. So we're going to just stop very briefly and go and have a look at population risks. The 2 population risks that we are going to briefly look at are the population attributable risk and the population attributable fraction. So essentially these questions are looking at ways of answering how much does a risk factor contribute to the overall rates of disease in groups of people rather than the individuals. So the others are really looking at the individuals, very useful for the cohort study. But what happens if we want to look at how that plays out in terms of the overall population? The information at the population level is really useful for determining which risk factors are important to the overall health of the community. And that's not surprising that these risks are then used when prioritising healthcare resources. So if we have a look at the first one, the population attributable fraction, it is essentially the attributable risk times the prevalence of a risk factor. It measures the excess incidence of disease in a community that is associated with that risk factor. The second way is the population attributable fraction, which is calculated as the population attributable risk divided by the total incidence. And it really is asking a question of what fraction of a disease in a population is attributable to exposure to a risk factor. We're going to leave it there. Thanks very much.